thought I'd start with the depressing bit and then try to become upbeat. This is a patient I've got to know very well over the last 20 years. When I first met her, she was walking, and now she has an EDSS score of 9.5 and is in a wheelchair. And I don't think that either she or I believe that her condition is worse than being dead. She still gets a bit of a buzz out of life, but it's jolly hard work. And what I want to do in my work with MS is when I see a new patient, like Simon, who you met this morning, and feel I have to tell them the truth that they have multiple sclerosis, I want to look them in the eye and say, we will now be able to offer you a treatment which will reduce your chance of becoming as disabled as this. Now, the tricky part is how honest can I be in saying that? The fact that I have patients who have done very well, whatever treatment they've taken, doesn't necessarily mean the treatments work. It's wonderful that some people do well, and I'm going to emphasize to you that MS often has a benign prognosis, and for that reason we don't want too many bad side effects from treatment. But we do have to work towards preventing very severe MS like this from happening. But let me reassure you that only a tiny minority of people become this heavily disabled. The big problem that we face in trying to fix MS with current or future treatments is it's two different diseases. So on the one hand, there is the relapsing illness, which is an immune disorder, and on the other hand, there is a progressive disease, which is a degenerative disorder. And I want to believe, I do believe, that MS starts as an immune disorder and becomes a progressive disorder. And if we can fix the immunity early enough, then we can prevent the domino effect of turning it from a relapsing episodic into a chronic progressive disorder. But there is an act of faith there, and I make no bones about it. I terribly want to believe this. That is the basis of our work. And if people say to me, you should be looking more at progressive MS, you should be looking at neuroregeneration, you should be looking at prevention of nerve cell death, I would absolutely agree with them, but I don't know how to do that. But we do have a methodology for approaching this, which is a relatively short-term illness, so you can get some results from your studies. It normally begins that way. But please remember, those of you with new MS, that after 20 years, 4 out of 10 will have benign disease. That is, will look normal and live a normal life. And what we can do to help is we can squish the immune system, just turn it all down with sort of general purpose drugs, or we can change the immune system. And there's no doubt that all of these drugs have a benefit. The question is, how big is the benefit? What are the side effects? What are the long-term effects? And we want to prevent this from happening. Progressive MS doesn't always get worse. People do get better, and that can lead to an illusion that the treatment you've taken is good. Once you've lost nerve cells in the brain or spine, it's like a modern computer or a Japanese car. You can't fix it. In the complexity in some people's brains, not in mine, they've lost the ability to recover the nerves. Mine doesn't recover either. It doesn't work very well at the best of times. It takes a long time to happen. And so, yes, the bias of studies from the drug industry, they don't want to look in the long term, they want to look in the short term. It is a problem. It doesn't affect everyone. 1 in 10 people with MS never have a relapse. That's the problem. So we can't intervene for them except with experimental treatments. And what we want to do is to prevent it, to break this domino effect. Let's look at that a different way. So this is a very standard view of MS. And in the red at the top, we have on the y-axis disability or unpleasantness of disease, and on the x-axis time. And so this hypothetical patient in the first part of the red stuff has got 3 relapses, an episode of visual loss in one eye, an episode of double vision, an episode of sensory loss, all of which recover pretty well. But then the 4th attack, as we move into the middle phase, hasn't recovered completely. And then there is failure of recovery from these attacks over here, and gradually the patient gets worse. But it takes a long time for that to happen. So this is relapsing remitting MS, and this is secondary progressive MS. And what is the pathology? Now, it's like an iceberg. Most of it's below the water, and you can't see it. And all that you see is above this line here. And there are two things happening: yellow inflammation and blue nerve cell loss. And the difficulty is that you have a number of episodes of inflammation before the first attack, the clinically isolated syndrome. And at that point, you can see the previous attacks on the scan. And you can diagnose MS when you see that attack or when you feel that attack. And what we know we can do is to reduce the frequency of these yellow episodes. And what we believe, and I want you to believe it too, we won't all say it together, but think it, that by turning off the yellow, you slow down the blue. That's what we want to do in MS. But we need to do it without causing side effects. Because remember that 4 out of 10 of the people that start here never get to here. And so if the treatments are toxic, if the treatments are lethal, you're going to kill some people who would have been fine. A serious problem. Which of these drugs are going to do that? So here is the pipeline of drugs that are coming online, hopefully to stop people with MS entering wheelchair dependence. And as we're around the edge, phase 1, early phase, we can try it on the mice, we can try it on some brave few patients. And as you move in through phase 2, 3, we've got marketed drugs. So the drug industry will sell you these because they have proven a benefit. Maybe there should be another circle in here paid for by the NHS, which is a different matter altogether, isn't it? And so this week we know that fingolimod, or I can never remember the name, it's Gilenya. So it's like Giles with NYA on the end, okay, without the S, Gilenya. And it's now approved by the European community. Whether NICE will pay for it, whether the NHS will pay for it, who knows? So fingolimod needs to move from there into there. Of course, you can see some drugs that we do use, like Tysabri, and we know that Tysabri is a very powerful treatment for MS, but 1 in 500 people get a potentially lethal side effect. Bad news. And one of the difficulties with the more powerful drugs that are coming along is the side effect profile. So we already have some interferons, which we know do something. We know they have a benefit. But whether the benefit is good enough, I think many of us doubt. And that's why we're looking at all these other drugs. Copaxone, a bit like the interferons, has a benefit. Nivantrone or mitoxantrone, yes, it does something, but it's bad for the heart and may cause leukemia. In fact, some of the treatments are used for leukemia, like these two, which we're going to talk about later on. Some of them are antibodies. This is not Tourette syndrome, FC, coming back. And they do have some slightly funny names. So the Welsh will go for neris-pyridine, and out in the East End we'll have PEG. So PEG interferon, a slow-release interferon. They've all got funny names. It's an odd thing that drugs have funny names. I suppose not to confuse them with things that aren't drugs. I'm not going to talk about all of these drugs, you'd be pleased to hear. There are some things up here which I'm not going to talk about. So symptomatic treatments like cannabinoids and the pyridines, talking about modifying the disease, not treating symptoms. What I also was not going to talk about much was stem cells. So this chap's having some stem cell treatment. Because it's fairly toxic stuff, it upsets your immune system, he's got a thermometer in his mouth. It's not a cigarette, it's a thermometer to check he hasn't got an infection. And what we're doing is taking out a whole lot of cells from his bone marrow, not from his head, from his bone marrow. And there are some stem cells which are blue, very easily recognized, and then some more brightly colored T and B cells. And these are lymphocytes. These are the good folk, but actually the villains also of the immune system. They're the soldiers that do the good fire and the friendly fire. Now, there's an issue whether you want to get rid of the T cells or the B cells or both. And I'll a little bit come back to that. So what you then do is you kill off the T and the B cells, and you put the stem cells back in, but you also kill off all the stuff that's in the host. So you rebuild the immune system, and you take away those naughty cells that are stripping the myelin. Now, actually, all of the treatments I'm going to talk about are addressing white cells, addressing T cells and B cells. And what we need to do, whether you take them out of the patient and put them back in, or whether you leave them in the patient and poison them with drugs, I mean the cells, not the patient, you that way will turn off the immune domino effect of MS. What happens with bone marrow transplantation, with autologous stem cells? We all want stem cells to be the answer to everything. They're not yet. It is a very effective therapy. It stops relapses. It doesn't stop progression. Once you've entered the progressive phase, rebuilding the immune system doesn't change anything. And that's a problem. That's why people like me get a bad press from folk with progressive MS. Why do you treat the milder patients? That patient's walking. Why are you treating her? I'm in a wheelchair. I've got it worse. Why don't you treat me? Yeah, good point. I feel really bad about that. But I practice the art of the possible. The difficulty is that you've got a 1 in 20 chance of dying from having this done. Chap I was talking to at lunchtime said, I'll take that if it makes my MS okay. Gosh. And I can see why people are prepared to take a high-risk treatment. It is easy to believe that bad-tasting medicine is better for you. But the question is, does it keep one out of a wheelchair? So this is not currently available. What is going to become available? My personal bias is that this drug, alemtuzumab or Campath, is the bee's knees. And this is an antibody which basically destroys white cells. It stops your white cells from doing what they do. And it's an effective treatment for white cell tumours. It's used to treat leukemias, lymphomas. And we want to use it to treat MS. We have some data showing a benefit. We're looking for a second study, which we're doing at Whitechapel, in many other places also, to show whether it works. But it seems to work extremely well. The problem is that its side effects are difficult. So while it will turn off immunity in the nervous system, and I'll go through this data in a moment with you, it seems to stir up other immunity. And there was a patient who died as a consequence of an immune disease caused by this treatment. That's really bad. But it does seem to work for MS. So, just looking at the science, a year and a half of treatment, and the lymphocytes are well down. The B cells come back up. You're treating the lymphocytes. What does it do to patients? So these are patients who have not become disabled. Okay, so at the start, none of them are disabled, and on the alemtuzumab, the Campath, very few, compared with the interferon patients, become disabled. Same thing for not having a relapse. Big difference. Same thing for the EDSS score. Now remember that 0 is good and 10 is bad with EDSS. These are people with low EDSS scores of 1 and a bit. They get better on Campath, they get worse on interferon. Not as worse as they would have been had they not taken interferon. I'm not slagging off interferon, we can just do better. I want to do better, we will do better. In terms of relapse rate, is what that says, much higher on interferon, either 1A or 1B, than on Campath. This looks like a very good treatment. Yes, it has a lot of side effects. You need to prevent the side effects with steroids before you have the treatment, but it really looks like the way forward, and my guess is in a few years' time we'll offer this to everyone with new MS, and I really hope it keeps people well. What else can you do? There's another drug very similar to alemtuzumab called rituximab, and we haven't got so much data on this, and this just looks at B cells, a different way of addressing the immune system. But if you look at a small number of patients, only just under a year, 48 weeks, these are the ones on treatment having very few, hardly any new lesions, whereas the ones on placebo have a lot of new lesions. Same goes to the number of, that's total number of lesions, that's new lesions, showing just the same thing. A very big difference in the terms of acquiring new scars, new sclerosis with this treatment. Does it have side effects? Yes, it does. Very similar to alemtuzumab. But we are looking at highly potent treatments to really suppress the activity of the disease. And if you're going to do this, you need it early in the illness before the dominoes start to fall. What's coming soon? Coming to a hospital near you sometime, licensed in Europe this week, fingolimod. Okay? And the beauty of fingolimod is we know, I'm not showing you this data, it's better than interferon, it's better than placebo, it really works. Is it a cure? Regrettably not. It's quite well tolerated. There are issues about virus infection, about herpes. There were a couple of deaths on the high dose from herpes, but we're not going for high dose, and I'll show you why not. There have been a few cancers, in particular melanomas. Maybe these are people trying to get their vitamin D up, but the 3 melanomas. Now, maybe that's totally fortuitous, but I wouldn't want to be too glib about that. It is possible the immune system keeps on curing cancers. And if you suppress the immune system, maybe you suppress the repetitive cancer cure. But it does suppress MS. So we have the patients free from relapse, 100% fingolimod high dose, slightly toxic, fingolimod low dose, not so toxic. This is the dose we're going to use if it's funded, 0.5 milligrams. Compared with placebo, you see a big difference. Turn it round the other way, you look for freedom from progression, again a big difference. If you look at not having a gadolinium-enhancing lesion, that is not having a new attack of inflammation on your brain scan, at baseline, all the same. At 6 months, 12 months, and 2 years, great big difference between placebo in light blue and fingolimod in 2 doses in darker blue. But since the 2 different darker blues look pretty much the same, we're using the lower dose, not the higher dose. And this will be coming along. It will be assessed for funding by the NHS. I cannot believe they will reject it, but there will be a fight. And I think it's going to be for people with a lot of relapses, not for 1 or 2 relapses, but lots of relapses. How we define that is a different matter. But there are issues about side effect. It's not a wonder drug. We have no wonder drugs, I wish. So you can read through that. The main concerns that we have with fingolimod relate to virus infection, and that doesn't come up there. Different studies on fingolimod have shown different risks of virus infection, and plenty of people, we won't do a straw poll here, get herpes. It's one of those things that happens, but it is worse possibly on immunosuppressant drugs. But there are concerns about slowing the heart, about the liver, about swelling at the back of the eye. You've already got a problem with that in MS, so you don't want to make it any worse. Does it upset the breathing? So these side effects you see over a couple of years in studies. Are you going to get more of them with 10 years of treatment? We don't know. We have to wait and see. We have to monitor very carefully. So there are lots of drugs coming along. There's room for plenty of hope that the slightly beneficial treatments we currently use are going to be replaced by more beneficial treatments, but I am worried about side effects. So this slide is out of date as of Tuesday, but so we are awaiting a license for fingolimod. I bet you anything we get a license for alemtuzumab within a small number of years, also known as Campath alemtuzumab, we mostly call it alemtuzumab. There are lots of other drugs I showed you on the slide with the pipeline, basically antibodies and immunosuppressant agents. But as far as stem cells are concerned, whatever you read in the Daily Mail, it's not about to happen. Thank you for your attention.